just turn that off. Right. Hi, everyone. Welcome to February's Sharing Best Practice session. So today we have Clare, Steele and Dan from the Department of Health and Social Care with us today. I think the best thing to do is just to pass on to Clare to give us a bit of a background of who you are and what you do and your role in the Department of Health and Social Care.
Okay, I'll speak briefly for myself and then I'll let Dan speak for himself. Okay, so Dan and I are the new team in the Southwest, one in each region set up by the Department of Health and Social Care to provide a bridge between the department and the local authorities and care providers in the Southwest, because unlike the NHS, they don't have the same threads, the same control mechanisms, because local authorities are independent, accountable locally, and care providers are accountable to themselves, but also to CQC, but not to DHSC, who are doing their best to help everybody through this. But of course, they have their ways and means as a government department of doing it, which partly includes sucking masses of information up from you all. It's nearly driving everybody mad, the capacity tracker, etc. But all I can say is that the results get looked at and we look at them, we interpret them, we go back and check if there's outliers. We give a narrative to the Department of Health that links to the massive amount of spreadsheets and charts that they have. And so we provided my title is Regional Assurance Lead, because the minister and the department, who is pouring a fortune out and all of this guidance, trying to manage this, want assurance that what they think is happening is happening. And if it's not happening, why isn't it happening? And so some of the changes in guidance you've seen recently are because we fed back and you fed back, and through all of those stakeholder routes, things about testing and vaccination priorities, all of those things, we can influence on your behalf, and we can also understand and assist where there are problems at local level and explain to the department about what's happening. So I used to be, well, it's always the way, isn't it? I was the Director of Social Services in the Southwest and the Head of Service. So I was about 10 years in one of the local authorities in the Southwest and have been retired for a little while doing projects. So I've come back in to do this role for 6 months. So they're all temporary posts at the moment. So that's my background. So I do understand the sector. And when I was in Somerset, I had very close relationships with our CPA. And really made sure that I kept in close touch with them and understood the provider perspective. So Dan, do you want to?
Yep. So hi, my name's Dan. I'm an intensive support lead for the Southwest, which is a bit of a strange title, but basically what I do is look at all that stuff that you've put in the capacity tracker. So all the information that gets fed into the capacity tracker by you guys comes out to figures for us, so we can have a look at things and feedback to the department really about what's going on in the area. We're well aware, and I tell you, there are so many requests every day for more and more information to be put in the capacity tracker, and it gets batted back all the time to say that you guys are filling out far too much as it is at the moment. We're completely aware of that, but just want to let you know that we do use those figures all the time, and we also try to get things changed. For example, the questions around staff movement are quite hot at the moment, particularly in the Devon region, and I think the way the questions are worded does not aid you when you're filling them out. So sometimes we can get figures coming up that suggest that you're all using staff movement quite a lot, and it's not sort of controlled staff movement, but it's just it to the minister, when she looks at it, she wonders why there's so much staff movement going on in Devon, and that it's really our jobs to explain why that is. Use of agency, use of bank staff, all those sorts of things, and not just the fact that we've got loads of staff going from one care home to the other, which it looks like sometimes in the data. So that's part of my role. My normal day job is CQC inspection manager for Bristol, South Gloss and North Somerset. I used to manage Somerset before that, but I haven't made it down as far as Devon yet. So, and prior to that, I was a provider of services for people with learning disabilities. So I know the sector well, and that's one of the benefits of our team is we've got all kinds of people in our team, from people from CQC like Clare who are DASs or used to be DASs, and providers of domiciliary care and care homes and all sorts of people. But all the common theme is that we've all got a real experience and background of health and social care, and can sort of just put the meat on the bones really from the figures going back. But the other thing to say is we do have quite a direct ear to the minister as well. So what we hear on the ground does get fed back to the minister. And I think one of the things that I was quite surprised at when I went to the meetings is the knowledge of Helen Whately around the sector in adult social care. She doesn't just understand care homes. She's always asking about domiciliary care, personal assistance, and what we're doing about unpaid carers and all sorts of things. So that really surprised me, because I didn't expect the depth of knowledge in the sector, really. But we do pass things back, and she's really interested to hear about examples of where providers are finding things difficult, or where things have gone well, so that we can share them and adjust guidance and everything. So yeah, so that's basically what we do. And I often go to outbreak meetings and things like that, and support areas that are going through difficult periods. And I know that Devon went through quite a difficult period a few weeks ago, and I'm sure there's still pressures in the system now, but it was particularly bad a few weeks before that. So yeah, that's what I do as part of my role, and it's nice to see you all.
Lovely, thank you very much for that. In some correspondence when we spoke earlier this week, Claire, you said that it might be helpful for providers to give examples of how the COVID funding streams have helped. Can anyone give any examples of that?
Yeah, could I maybe step in before we launch into the detail of the list, that just some overarching feedback in terms of Devon Care Homes Collaborative, that in Devon there's been lots of efforts from providers to have collaborative work like the Kite Mark and Southwest Care Collaborative over the years. I think from our perspective, we'd really like to recognise that Devon County Council, in fact the Devon system as a whole, since the beginning of this pandemic, has massively pulled together. And in fact, a number of us on this call were authors to the Select Committee report last summer to say that actually the support that we've had has been far superior to a number of other counties. And I can say that working in have an organisation that works in a number of counties across the UK and South Wales, that the Devon support has been exemplary overall. And whilst there have been major glitches, and one of mine you're fully aware of, but that overall what we've had, the explanation, the support, the creation of Care Home Forum, without Care Home Forum, I don't think we would have been able to influence the system as a whole to respond. I think one of our emails between us says very clearly that we all started in an imperfect environment with a broken system, with systems and processes that don't work to support people in social care or health and social care at the best of times. So when the pandemic hit in the end of last February and March, we set up the incident room at Royal Devon and Exeter, and then from there it spanned out. That the willingness of the CCG and the LA in this county to actually just do things outside of the box has meant that we've saved more lives than we would have otherwise. And when we look at our pandemic numbers in lockdown 1, then I can compare this to Somerset, Royal Gwen, South Wales, in Cornwall, that our numbers are better in Devon because of that will by our leaders to say, sod our process book, throw it out the window, and let's just design a process for the problem we've got today. A number of colleagues on the national networks haven't had that positivity from their local LAs, especially in London, and where I actually live and have a number of caring friends. So I think we should start with that frame, that this call may well have lots of complaints that come out of it, but we're not just complaining, we are very cognizant, and it should go back to the Minister, we're very appreciative of the funding and the guidance and the advice. Having said that, do you want the list of problems? Are you ready?
I'm in your hands, except that I've been told that this was a good practice sharing session.
Sure.
So and one of the things the Minister does, they do hear about all of the problems, but
yeah,
one of the things they're very eager to hear about is good practice.
So we've got a brilliant list. Let's start with that. The Infection Control Grant has enabled the creation of Devon Care Homes Collaborative. I mean, without it, we would not have had the funding to put this together. And it's now public knowledge that £100,000 was awarded to this collaborative for its inception and for the creation of infection control advice. And some of that stuff is easy. We set up a WhatsApp group and everyone comments on it all day long. It's brilliant. If you're not busy enough on WhatsApp already, you've got 250 people on a Devon one. Half the time we moan at each other and half the time we moan at each other. But it's a peer support network that without it, I mean, I think we all go through very highs and lows. And guys, please just interrupt me when you think I say something wrong. But we go through highs and lows, and that peer support didn't exist previously because we didn't know each other. The grant enabled that. The grant has enabled us to work with the infection control lead at the CCG to develop an infection control champion system for care homes. So it's, for those of you that don't know, and we haven't announced it yet, so sorry, but in 2 weeks' time, once the programme is ready, we'll be launching for an infection control champion from every care home in the county. We're very cognizant, and maybe the Minister should be aware, that residential care homes being told in lockdown 1 to institute barrier nursing techniques, I felt as a nursing provider was very unfair. How were the individuals supposed to have that training and the skill set amongst the staff? And the CCG was through the district nursing network was unable to upskill people that quickly. So an infection control champion program that's a proper structured training course with audit forms and blah, blah, that we've managed to create. We haven't had that much support from Public Health England, unfortunately, in the Southwest, or not as much as we'd like. But we've got to a point where actually we've got some real good stuff going out. I might just shut up there because otherwise I could talk for the entire day, as you know, so I'll let other people talk.
I think Robin's got his hand up.
Thanks, Joe. Yes, I think in terms of sharing best practice, one of the most useful things for me that we've been able to do is we've been hit with a high volume frequency of guidance from numerous sources, and if you read that in isolation, often it is very hard to come to a judgment of what the heck does this mean. And the power of having the group is that we've been able to have Zoom calls and WhatsApp chats about what does this guidance really mean? Does it mean we've gone from 14 days to 10 days? What's the circumstances that applies to? And that has been really beneficial because interacting with other professionals, they're often as unclear as we are. That's what the guidance means, and if you're not careful, you get a whole train of actions carried out, and 2 weeks later you discover, oh no, we've got it all wrong. So for me that has been really powerful. While I've got the microphone, I did just want to ask Dan and Claire, it'd be really helpful to understand the information flow from Capacity Tracker. So I understand it going into the centre, but to what extent is the information that's extracted from Capacity Tracker shared with, for example, our local NHS trust, our CCG, our local authority, and at what level? Is it at a locality level? Is it overall? I just have no appreciation of where the information gets to, and from a perspective of whether I should expect that professional to receive that information and therefore be aware of the picture or the circumstances that we face. Sorry.
Dan, do you want to have a go at this?
Yeah, no, I'll do that. Yeah, so a really good question, Robin, and one that I ask myself a lot as well. But the basic answer is, for the capacity tracker, is local authorities and health authorities have access to all the information in the capacity tracker. Okay, so they do have access to it. Now, saying that, it is not the easiest thing in the world to access, and some people will access it better than others. And I think one of the problems that everybody encounters is actually people asking you for information that they could have got from the capacity tracker, which is so irritating. And I know that there's a huge team of trainers that's available to anybody in regards to the capacity tracker for free, and they'll do it immediately and show you how to pull off the reports and get the information. The other thing that comes from the capacity tracker, which has been rolled out more recently, is the adult social care dashboard, which basically takes that information and puts it in a much more usable format. So you don't actually see the questions you're asked, but the information comes down in a much easier way. You can filter it far easier by like local authorities or locations or anything, right down to the granular information. That's only just been made available to local authorities in the last 3 or 4 weeks. So they're still getting used to using that. I use that quite a bit, to be honest, rather than the capacity tracker. But the information that comes through there is available to most people. And what I used to say to people in some of the Bristol forums was, really, sometimes don't be afraid to challenge people and say, well, can you find this information out on the capacity tracker, because I'm busy. Do you know what I mean? Sometimes they might want to know why that entry's on there. But I think sometimes it's right for all of us to challenge people back and to actually say, can't you find that information on the capacity tracker? Because that's what we're asking you guys and everyone to do, is to complete that. And we know how long that takes for everybody. And yeah, and if they're not using it properly, then that's a fault, really. And that's something that we try to promote all the time, and the team, the training team, so that people can have those one-to-one sessions almost immediately on how to get the information. Because you're exactly right, Robin. But most of the organisations will have access to it.
Okay, so I mean that's helpful. Just a couple of quick follow-ups, if I may, on there. Whenever I've been involved in information systems, I always believe there is far better buy-in if the provider can see the outputs.
Yeah, yeah, we've been pressing for that as well.
Okay, so that
yeah, it's something that we've been pressing, and lots of people have been pressing and continue to press that argument that people should have some, because be useful. I know exactly how it would be useful for you. There'd be an easy way of seeing your history through this pandemic on there for a start, but also it would allow you to benchmark yourselves against regional averages and things like that, and all those kinds of things. So we keep pressing the point. I can't say whether that will ever become available. There are some deep, questions about GDPR and that, but I'm sure there's some ways they could get around that with rationalising the figures. But yeah, no, that it is constantly brought up, Robin, and constantly pushed up from us around access, because we know how useful it would be. Because it must be. Sorry, Claire. I was saying, go on.
It's the point is that if you want people to be committed to entering good quality data, they have to have buy-in to it.
Yeah,
and
absolutely.
the best way to get that buy-in is that they can then use it themselves for their own purposes. So I'm sorry to interrupt, Dan, but
no, that's all right.
We keep sending this message up, and there seem to be demands from lots of different directions about, please could capacity tracker do this, and please could capacity tracker do that. Can we have this question and that question and the other question? And our seniors in the adult social care section of DHSC tell us that they work quite hard pushing back on there being endless additional questions that somebody would like to know the answer to, because it's just becomes more and more impossible for you to be putting the data in. So I've no doubt that they are also asking, because we've heard them say it to us, about being able to get feedback for the people who enter the information in the first place. But there's no success on that yet.
Right. Okay.
I mean, it'd be interesting to see. I think the question is, will capacity tracker stay? Is it hit with us forever? Because if they decide that this is a way of getting a good idea about what's going on in the care sector, which that DHSC feels that it doesn't know what's going on in the care sector, they may well make it a permanent thing, possibly part of contracts because they can't make you do it. There's an advantage to you doing it in terms of accessing grants, but I think that if they're going to carry it on in the longer, calmer term, then they've absolutely got to enable you to be able to interrogate your own data and benchmark yourselves. Absolutely.
Could we understand, sorry, another follow-up, Robin, that on staff movement, Dan, that you mentioned earlier on, could we just understand that? So if I was a cynical provider, and everyone knows that I'm not a cynic by any means, but if I was a cynical provider and I was asking to say that the data that you're collecting, is it seeking to control us? That the staff movement issue, and I'm not saying that you are, I'm just saying, but if there was a staff movement oversight, where can I just understand how that data's come through? How are you judging that there's staff movement in Devon?
Right. Okay. I think one of the things to say first is I think our team was set up too late. Right. We missed the bit, the early bit, in the sense of trying to. There was something during the first wave where somebody picked up on the idea that agency staff may well be going from one home to the next and spreading coronavirus from one service to the next. And it was one of those ideas that stuck in people's minds, and the example stuck in people's minds, and it turned staff movement into a thing that is seen as potentially bad. Right. But what they didn't understand in the sector is that the sector would not survive without agency staff, bank staff, some movement between services, just the way people are employed and things like that. So that has to happen, but they're still having that difficulty. Now, what we look at is the questions that you were asked under the IPC section of it, and forgive me, because we never see the actual questions you're asked, we just see the answers. So there's something around like, do you have staff movement? Do you have staff movement, but have you exhausted all other methods before using it? You'll probably know the questions better than me, Shrin. You'll be able to tell me what they are.
So I get that the drive around staff movement. So my question back to the department is then, there's been an onus on providers to reduce staff movement, and I totally get that. We at the beginning over recruited an agency, and those agencies been with us all year. And it's easy for a bigger provider rather than a small single provider. So there may be that challenge. But the bit I don't understand is that if there's a focus on reducing footfall through the care home doors, because that's going to keep people living there safe, we focused on staff. Why has there been no focus on professionals? So as a provider, I've had many robust conversations in the last 11 months with professionals demanding to come through the front door because they felt it was their right. But when I've developed a very detailed question list for every professional. If you don't answer it, you're not coming in. When they answer it, where have you been in the last 7 days? And when you see a list with that professional having been in 5 other care settings and sometimes having been a hospital, they present much more of a risk than my very dedicated care staff who have got much better IPC practice and don't go out anywhere with socializing with anyone, versus the professional that's going into a different institution every day of the week and spreading COVID. So I can't see an equal parity there.
No, and I know what you're saying, but the thing is, those professionals have got a job to come in. They're not coming to your home for fun. They're coming to do a job. At the moment, moment they're being tested on a weekly basis by their organisation. If they're coming from the CCG, they will be tested through that.
But isn't that the same? Isn't that the same for care staff? That they're getting weekly, twice weekly LFT testing and a weekly PCR test. So if I was looking at just from a risk management perspective, if I was running an agency today, and our agency's been really good, Ocean, for example, they're really good in terms of allocating staff to a dedicated home. but it seems that there's one set of risk analysis for a group of people, the care staff, but a different set of risk analysis and rules for the professionals.
I think one of the things that, you know, the testing regime has been brought in because of concerns around that.
Right.
Okay. But the plain fact is that those professionals are going into your home to do, well, I know what you're saying, agency staff are as well. Okay.
Yeah,
Or staff are coming in, but they are coming in there to do a particular job for the health and well-being of your residents. So now they're tested on a weekly basis. That's what's seen to be the risk around it by the department and by PHE.
Sure.
Around it, you know, that's their decision, and that's what they'll do, you know, and come in. So, I mean, that has changed. They weren't. I mean, as you know, CQC inspectors weren't tested originally, and we were going in different settings, and I was doing IPC inspections in settings, you know, and there was a week between inspections, which, you know, nobody felt comfortable with. But now they're tested on a weekly basis with the PC.
But you had an incubation period. You had an incubation period, right? In your week between that, I could understand CQC strategy. I guess
it wasn't long enough. It wasn't long enough.
Sure. But in terms of advocating for staff, it feels like the health professional, my staff aren't health professionals because the health professional word gets a different rule, but the carer isn't regarded like that and is given a different set of standards and bars to work towards. And I feel bad about that.
I suppose what the answer is the beginning to my bit is, and why we're here really, is a misunderstanding of how the care sector works. That's purely it, down to the beginning. The whole thing is they thought you were getting a different agency staff member every day, and you know, one day they would come to Oak Tree Care Home, and the next day they were going to and we know that providers, even at an early stage, were making sure if they were using agency where they had to, they were contracting them on a longer term basis to keep them. You know, they were restricting staff movement as much as possible. But it's just something that's stuck around staff movement. And in the statistical analysis that they've done of many parts of the first wave, they identified common themes in services, and one of those common themes that stood out in the analysis was staff movement. So it's stuck there, but it's forever something that we are trying to really bounce back on and explain around those things. And we know that you know, it is a difficult issue, but we also know that in counties like in Devon, you will have people who will have a 20-hour contract with one home, and they might do a 10-hour contract somewhere else because that's all the jobs they can do, or they might do some personal care for a DCA, or you know, it's just that's the way people
last bit from me on staff movement, then I promise I'll shut up. But I can give you one examples from Evolve. That a home out in the sticks in the middle of fields, one of our homes, there's staff that worked with across multiple homes. We simply, the two of us as providers, spoke to each other at the start of lockdown one and said, and we picked members of staff, and the ones that were part-time and there came full-time for me, and two of mine that were part-time and went full-time for the LD facility, and that was done, and that we had no staff crossover. So from the conversations that I have with the provider members of DCHC, we're not identifying staff movement as a problem today. So it'd be really interesting to know how we can help provide the department with better information to say that's not how Devon is. If that's the picture that's being painted, how do we give you information to show?
Well, I tell you what, Sharon, if we can organise a call between me and you, and I can share my screen and stuff, and I'll do that afterwards, and we can go through the data, and it may be just the way people are answering the questions.
Yeah, fair enough. Yeah, I'll take that down. Yeah,
and we can sort that.
Definitely.
Thank you. I'm happy to do that.
Cheers.
But yeah, we know how difficult it is. Sorry,
I don't know how to raise my hand. So just a question on staff movement. One of the things that we've found is when we've had an outbreak is public health have started to ask for information about who our staff live with, and then almost implying that we shouldn't have had staff working for us if they work in another healthcare setting. Now this really crosses lines of what we can and can't do. We don't have the right to say to our staff, you know, no, your husband can't work in the NHS, and you know. So I think just to feed that back, because we've literally had quite a few examples where they've asked what our staff's partners or other people living in their houses do, and that's just going, you just can't ask that question or do anything with that information.
I think,
and are you even aware that they're asking that?
Yeah, it's really, it is really difficult because they come from a tracing background, really, PHE, around that, and there have been lots of outbreaks that have actually had staff that have, you know, one partner might work in the NHS and another in a care home. So it's a sort of question that they ask, but they're not thinking about the effect that has on people. I mean, really, that's a job they should be doing in their test and trace role, as opposed to in the IMT, you know, whatever you call them in Devon, those supportive outbreak meetings that you have with them. They really shouldn't be asking those questions at that. And I think that's good feedback, and I can feed that back to PHE around that, because they're right to think down those lines about where this possibly goes, but they're bringing it into a different setting.
But also, you know, if you think there's 2.3 million shielding, they've announced today there's going to be an additional 1.7 million. We've already got vacancies. You know, if they then start telling us that our staff movement can't be that any household member can work in another setting, you know.
I've not heard any suggestion of that. They're just, the HPE, I think Dan is right, they're asking it in the wrong context. When you're feeling, you know, on the ropes already because it's about an outbreak in your care home, although they try not to make it in that atmosphere. But HPE are trying to understand it. They can't do anything about it. It's just the nature of it. But I agree, it can feel very uncomfortable if that is the circumstance at which it comes up.
So just, thank you.
But no, that's it. I mean, like Sharon was saying, the Devon system I think's worked quite well on the whole, which was why I haven't really been involved in Devon that much, because I've been looking at other areas in the southwest. But you know, I've certainly worked in systems where people have fed back similar things to that, Louise, and they've actually, you know, have taken that feedback on board and changed some of the ways that the meetings are run. So I always think it's worth feeding back things like that, and I will as well to Devon about that and the feeling, but more generally across the southwest. But yeah, I think sometimes it is worth feeding that, because I know that Bristol made huge changes to their outbreak meetings after initial feedback from some registered managers that the initial ones felt like a bit like a being the registered manager was sat there in front of
interrogation
30 people being interrogated on everything, and it made huge changes in the way the meetings were adapted and much more co-production between the service and the local authority. So yeah, but I'll take that point on board.
Has anyone else got any questions or any examples of good practice relating to the infection control fund that we've had?
Maybe if I could reel off a couple from our, in terms of Devon Cairns Collaborative, we found it really useful to share ideas about how the grant was to be spent. And initially that was because we didn't understand what the criteria were, but what came out of that session was people had some really good ideas. I remember those, I don't know if the provider's on the call today, but had a tour bus outside that was used both for occupational staff and as an area for staff. So it was outside of the building, but you know, there were innovative ideas that we could all learn from, but by sharing in that front, through sharing how to spend that money. The testing one that's come out, and I'm not sure I'm talking about England or Wales now, so I'm going to shut up in a minute, but the testing one that's come out with a grant that says that you can use that to build a testing area outside. There's been an email trail and WhatsApp stuff about how providers are doing that, especially for LFD testing. The available on the vaccine front, when we had a real nervousness around vaccine coming out and staff refusing it, and early on DCHC held a vaccine best practice sharing session where we had a panel of people and staff. That was a huge attendance there. The staff challenged a microbiologist an infection control specialist, a care home manager, and a care home director on why they should have the vaccine and what the effects of the vaccine were. Guy Mozolowski from VaxSupport has been instrumental in Devon in advising all of us and providing Vita assay LFT tests made in Spain at the beginning. So a number of us purchased those privately when testing wasn't available in Devon. And it was all through Guys educating us that happened. And obviously the availability of the front. The other thing I'd like to just point out for Devon is that the availability of PPE at the beginning in lockdown 1, which some of us may have forgotten, was phenomenal. Their response to providing it in comparison to Somerset sent you 10,000 small gloves and said, get on with it, and delivered it to our front door. And they spent their 5 million buying their own PPE. Well, I had a nightmare in Somerset in my services there, but in Devon, it was really good.
That's good to hear.
But just following on from the PPE in first lockdown, which is obviously a long time ago, because we had this kind of conversations going between different providers, that actually one provider had sourced masks. And so there's a few of us on this call that actually met in a service station car park, socially distanced in lockdown in order to get our boxes of masks and stuff, because different people had different contacts. And so that was all going on. Shirin wasn't actually him who was our car park.
It was the illegal taxi driver, do you remember? Extra service station. Anyone, mask anyone, mask anyone.
Yeah, we had the police circling us. I was like, feel free to come and interrogate us because we are doing this for genuinely good reasons. But, that was a really good use of connections that we had forged.
So in terms of the most recent grant that's come out at this very late stage of the workforce capacity grant that just runs until the end of March, and the authorities put their plans in last week, which, by the way, we have not seen yet. Were there any particular things that you went for in Devon to use this extra money, this short-term extra money for?
Devon have come out with a fairly, I won't speak for others, in my view, a fairly good scheme. That the smaller homes are able to apply specifically, and I believe, correct me if I'm wrong, but under 20 beds. And then if you're in an outbreak and you have more than 5 staff isolating, I believe you're able to apply for an outbreak support grant of £10,000
to support income.
Yeah. So in terms of immediate access to staff, I guess Devon have had an agency contract at the beginning, so outbreak homes were supported by agency staff, and then our Proud to Care campaign has been really good and really fruitful in Devon. So Sally Ann Turner and people that run that have done a great job at providing candidates.
Yeah, so I fall under, I've got 3 county, I'm Plymouth, Torbay and Devon. Right. And each of those has chosen to do something different with that latest workforce. One, I think I'm still waiting to hear what they're doing. One has given us a set amount, which we are to use for paying for holidays that haven't been used. And then obviously Devon, as Shirin said, there's a small provider and an outbreak. And you can only apply for one, so you can't get it twice.
Could I just ask on the grant front though, there's one particular local authority that is insisting in our area that is insisting that the provider tops up someone who is self-isolating from statutory pay to full pay using the grant allocation. That terminology wasn't in the grant agreement that providers in that area have signed. And I think it's Plymouth. And if they're insisting upon the grant to be used in that way, and they're threatening from my reading of the email that's come out, a full-on audit and possible reclaim of money if the grant hasn't been used to fill up staff wages. That, in my view, that's a crazy assertion by a local authority to make to any claim, because you don't know how many are isolating. And it wasn't in the original grant conditions either. So to be putting those retrospectively doesn't feel like working in accordance with the values of how our sector should work.
We did check with Devon on this because I think how part of it came about is that staff who had been isolating, some had applied for that £500, and some of them were told that, oh, your employer's got an infection grant, you should go to them. Devon did take the position that grant wasn't solely for paying for isolation, and you know, that homes could meet the criteria and it didn't have to all go. And so therefore those staff that have applied have received that payment from the council, if that's who's funding it. But Plymouth are categoric that despite the terms of their grant saying that you could meet one or more of a criteria, they're saying no, that's not what they meant by their terms.
Interesting, isn't it? How different it can be from one authority to the next.
Yeah.
Very difficult for you.
But it's also, and it's silly things that, you know, you fill in a form. So we've all got the same grant. Each area has chosen a different way for us to fill it in. And one says that, you know, despite you may have paid more than what your grant is, you're only to declare what your grant spend is. Then another one says, well, we do say that, but actually you should be declaring more. If you've spent more, you should be letting us know. And you just think, if you haven't asked for that, could it not just be the same? It would make life a lot easier. It's a silly thing, but it really would make a difference. Anyway, I'll stop. Sorry, everybody.
No, it's very helpful, Louise.
Can I just read out, there's someone on the call who's written a message to say that they work in an LD home, and they've mentioned that they found the latest grant disappointing. She says, we have a very high staff ratio to bed numbers and had hoped to use the money to fund a temporary testing operative role. The grant doesn't remotely cover the cost of this part-time role.
Yeah, thanks for that, Joe. I did see Kimberly's comment and also the comment above from Louise as well in regards to the capacity tracker. Hopefully I'll sort that out with Shirin and we can get some message out about those questions. But yeah, it's the thing is, it does sound like an awful lot of money when you quote the figures, but by the time you've divided it by the local authorities, then divided it down again to services, it's
and ironically, the amount of reporting they're wanting on it from the local authorities and therefore, and also back from you, is phenomenal in relation to the small amount of money that it is. It may only represent the difficulty they had at getting out of the Treasury, that the Treasury's insisted on that amount of feedback and right to claw back. You know, it's not helpful. So nobody's felt that this, you know, you can't complain that you've been given some money, but at the same time, it's problematic. It's problematic money in lots of ways.
Could we ask one quick question back to the department? It may be that you're not able to answer this one, so apologies for putting you on the spot. But how does the department feel that it's handled this pandemic and the risks in social care? Does the department think it's done a good job?
I couldn't possibly answer that for the department. I've only been here since the beginning of December.
It would be nice to have an answer from Helen, if it's possible, on Helen's view. Yeah, please, please do that. I'd be very interested, as one of the conveners of this collaborative, to know how the Department of Health, Department of Treasury, and Department of Social Care, and I appreciate you're an SC, so I'll put my question to the other ministers separately, but how do our ministers actually think they've performed in comparison to the international stage at supporting frontline workers on the ground who are risking their lives every day in difficult circumstances to try and save lives? I'd really like to know Helen's answer to that.
And I think they get that question from a lot of reporters and commentators and the opposition as well. And so we only get a spun answer on that. The only thing I can tell you about the adult social care section of the Department of Health and Social Care, bearing in mind it's only very recently been health and social care, is that just early in 2020, there were only 30 people in the adult social care side of the department, mostly policy development officers.
Right.
And now the totality of that, there's about 300 altogether, a lot of whom are analysts. And I don't know quite how they break the number down. There's the people who've set up Capacity Tracker and the people who've set up the social care dashboard, and ourselves and the analysts and more policy officers and so on. And so they are all of us coming on very fast, and that we can feel week by week the team still shaping up. And
so how do you apply for a job?
Sorry?
I did apply for a job. There are loads of us on this call that would love to be policy advisors to
Well,
to the
I don't know
department.
I don't know how you get a job as a policy advisor. You've probably got to have a very good degree to get a permanent job in the DHSC, but I heard of it through ADAS for my temporary post.
Okay, so shouting loudly doesn't work then, no?
Not usually, no.
Okay, I'll shut up.
Right.
Lovely.
Anything else people would like to tell me that you know it's something that you've done really well and you want people to know that that's gone well? Because you can always write to me about the problems. I mean, I'll put my email address up.
I think we've been really good at collaborating.
Great, yeah.
Getting each other through things, and I think sometimes that WhatsApp group is just literally pulled. I'm sorry if people already made this point, but you know, thank goodness for that WhatsApp group sometimes.
Can I just I made a little list of things. And be careful with words, but I'll a list of things. But
Jeffrey, we can't hear you very well.
You're breaking up a bit, Jeffrey.
I've got a rubbish internet, I think, where I am.
Turn
So
your camera off.
hear me?
Sometimes that helps if you turn the camera off.
Okay, I'll do that. Does that help?
Yes.
You don't have to see me, which is probably way better.
We know who you are.
Yeah, unfortunately. So, right, with Shreyan's already alluded to the work of the collaborative, and I think one of the significant things in terms of the early days of the pandemic, I can't remember if you mentioned it or not, Shreyan, but I thought it was particularly significant when we agree with all of the health providers.
No, Jeffrey, we can't. You're really breaking up.
Write it in the chat, Jeffrey. Write it in the chat because we can't hear you.
Okay, sorry. Okay.
In the chat.
Okay.
And next time, get better internet connection, my friend. Come on.
Yeah. Okay. Thank you.
If you look like you were wanting to.
Well,
Yeah. Can I just? I'm sorry, I got onto the call a bit late, but I don't know if this has been discussed before or not, or is it for this right forum or not? But you know, the situation is when you have an outbreak with two people, outbreak in the home or staff or residents, and we've got a 28-day embargo, and certain areas around the UK, we've managed to agree with the CCG and the public health to say that we can cut that embargo to 14 days once we've had a clear run of 2 weeks of nobody being positive. Is there, I mean, if people can come back, if staff can come back after 10 days of having had COVID back to work, I don't see this. Can we look at this 28-day situation? Has everybody got any information on that or any response to that?
Yeah,
to cut it down to 14?
Arif, unfortunately, that decision is made by Public Health England on a local level, and you're quite right that in some areas where they've had issues around capacity, they have in their homes, they have made allowances and risk assessed and opened up homes shorter than the 28 days.
Yes.
For the majority of places, they've stuck to the 28 days. There's no official guidance on how many days a home should actually be closed for. It's based on the PHE guidance and what they suggest, and that is the standard is 28 days. And with regards to the DHSC, is we go by the guidance that the PHE sets because they're the experts on infectious diseases and infection control. So it's really up to your local systems to do that. And I know that other areas have put risk assessments in place where, for example, they've opened a section of the home again for readmissions that isn't affected by COVID. If it's a setting, and many of them won't be, but if it's a setting that has a separate wing or a separate floor that can be done like that, people have done things like that. But those decisions are made on a local system level, yeah, as opposed to a national level, unfortunately. So
yeah, okay, yeah, Daniel, I understand, and I think that because we have homes in various areas, I have to say that the director at Public Health England there, or the representative that we speak to, once the risk assessments are in correctly and everything is up to the mark, then they are opening up within 14-15 days of the last case of the pandemic. So I'm just saying, and I think Devon have been proactive in Exmouth, where we have managed to open up a bit earlier than the 28 days where we spoke to Public Health England with their guidance and with our local public local CCG, everybody else, we managed to actually open up early. So I'm just wondering whether we should try and look at this as a policy wide, because I know that we want beds to be filled, and 28 days seems a bit, a long time when they need us to help them out. So I think that it's something we should be pushing for a bit more, so that we can start filling some of our empty beds now.
Can I just also support that? Because, for example, I've had an outbreak in Devon, and we did speak to the outbreak team, and it was agreed that Devon had 9 criteria that you would have to meet in order to open before those 28 days. We could meet all of them. We've actually made a decision to wait a little bit longer. But Torbay, I had 2 staff test positive. One of them hadn't even been in the building because they'd had their vaccine and been reacted to the vaccine, tested positive. They will not let me open. So 28 days, no resident, no other staff. So I'm not allowed to open for visitors. I'm not allowed to open for admissions for 28 days. No discussion.
I know
It doesn't make sense.
it is really frustrating, and I know you've probably had services in Devon, some of the largest services, but we've had services in Bristol that were under a embargo for months, because they would every now and then have 1 or 2 staff testing positive.
Correct.
Before the 28 days it ran out, and they had to take action in the end against that.
But in terms of, and sorry to talk the opposite way, but in terms of infection control practice, the suite of 2 clear negative PCR tests a week apart gets you to 28 days. So the 28-day embargo and I'm not talking, I appreciate the point around the business, but infection control word dictates that the 28 days is the safest way to do this. The biggest gap that we seem to have in our marketplace is the lack of understanding around zoning. So you alluded to there being a wing. So myself and my clinical director are co-authors of the Bush-proof care home zoning document, which Public Health England have not yet adopted in this country. And I would invite the both of you to look at it on the Bush-proof website. It has a very clear zoning protocol in place and advice for care homes. Now, there are a number of care homes in Devon that have zoned. Now, as Evolve, we zoned at the beginning, and I spent over £500,000 putting in infection control zones across 7 services. Those zones are a clear protective feature. So if a home is able to demonstrate zoning, then readmission into, as you say, a new wing or unit, but it doesn't need to be a wing, does it? It just needs to be an identified zone with the right policy and procedure, the right dedicated staff. The current public health guidance doesn't even account for the fact that now in Wales, we had the same problem 9 months ago. We approached Rhiannon Stifford and William Beer, myself and Eve have convinced the Public Health Wales Board to recognise zoning in Wales. We've had no response from Public Health England. So it'd be interesting to know why Public Health England aren't listening to best practice on the ground.
It is interesting though, Shring, because in the meetings that I go to and the advice they give, although I know that there's nothing published on it, is one of the key things they look at and suggest to services as good practice is zoning and staff bubbles within those zoning, and they see that's most key.
But there's no guidance. It'd be really good to see to our sector that actually we are forced in a way through proper guidance to have proper zoning policies in place. And I'm not going to make myself popular about my provider colleagues by probably saying that because it's expensive, but that if that is the way we're going to go forward to protect the citizens of our country going forward in the future, that zoning in institutions must be there, and any home above 25 beds must at least have 2 different infection control zones. And unless we move to guidance on that fact, our sector won't get there. So it'd be really interesting for that to go forward and happen.
Well, I entirely understand the point you're making, and that is the sort of thing that zoning is a way out of that problem at the moment. That we know that there are care homes that the building just doesn't allow for it, and we're rather dependent on a lot of care homes whose building doesn't allow for it.
So can I give you one example though? We had a co-provider on here in Exeter who had an old building. They said the same. When we did the consulting call, it took an entire Sunday to zone properly. It is possible if we had the support.
Not saying it isn't possible, I'm saying there'll be some buildings where it's a very difficult and expensive thing to do
Sure.
on a longer term basis, because we have other infections besides this terrible one. We also have norovirus and we have flu and various other things ripped through. I'm remembering back when the environmental changes came in from CQC in the late 1990s, and that devastated Devon. I was in Devon at the time in the health services, right across Devon. So many homes exited the market because their building just wasn't going to be able to meet the environmental requirements. And it's a matter of, things like that are a matter of gradually managing the market changes that you need to provide the environments that you need without losing really good providers in the meantime. So I agree with you that it's about best endeavours, and it will impact on this 28-day thing. But in the longer term, it's something that may need to come in as a broader. I think a lot of practice will change in terms of environmental requirements as a result of COVID.
Sure, but the environment becomes one part of our zoning, but staff cohorting, service user cohorting, and the training in that respect, ensuring that you've got separate trolleys and the laundry stuff. So without necessarily thinking about the doorways and the stairwells, entrance and exits, but the approach from public health. And maybe therefore to affect funding, and that's where I'm going with this, that if our guidance from public health was that cohorting and that type of thing are required, the department would then have to fund that type of requirement. And that's how we approach this in Devon, to say we've got a central infection control policy that we're working on, because then health and social services will have to fund the application of that policy. That policy doesn't require environmental changes, but it does require, for example, isolation after norovirus. And so we've covered all those different scenarios in a potential policy. And if that gets agreed cross-sector, that the commissioning side of this, it supports the provider to provide good care. I know, and I can talk about my organisation, we sometimes have to cut corners due to money, which just isn't right, is it?
But I'm not disagreeing with you. I'm just talking about timescales, really.
Sure.
And you're talking about the funding aspects of it, yeah.
Well, because I wanted to ask about the fee consultation next.
Can I come in?
Yeah, so
I am a small provider. I mean, we are a Grade 2 listed building, and so I hear the constraints. But we split the building into 3 zones, built 3 completely standalone PPE stations, and then we obviously risk assessed the team. And then I took on 7 additional staff to try and make it work. And we've had 2 cases, and no one else got it. So I'm guessing amongst the staff. So I'm guessing the infection control measures are pretty effective. Touch wood. but Shireen's right. It is staff. It's the cost of the staffing.
I know.
It's massive. I mean, we're a tiny provider. Well, I say tiny. I'm 14, but the cost of staffing is. Yeah. I think it's in the region of about 85k.
And it's one of the things that puts the market in jeopardy, you know, care providers in jeopardy. And so we know that there's been a small inflationary uplift offered through to the councils for this coming year. So and I know that in terms of ADAS Southwest, they're making very strong representations that the uplift just isn't sufficient to support the staffing costs and so on, and provider costs going forward. In addition to which, because so many fees have been inflated for different reasons, it's going to be very difficult for providers and for councils to step back from those inflated levels back to where they were before. So there's another market study going on between the Department of Health and the local authorities across the country to try to understand the degree of risk. Now, in terms of, I mean, Dan and I will pass anything up to the department, but in terms of our jobs, I was asking 1 or 2 questions last week about some of these broader, longer term things, and was told quite clearly, your job is COVID for 6 months. And I found that quite difficult, because actually I care about the sector and I care about provision, and it's not just about now and COVID. For me, it's whatever is happening in COVID is going to impact on the future. So we will pass it up, but my ability to, other than amplify your voice there, is limited, because they see it as beyond our remit and they're using other routes. But and I'm sure through Care England and other routes you'll be making your own voices heard, because the local authorities really care about managed change in their markets, not free for all, problems because of unaffordability, and there's so many questions to be answered yet about how the money will be for after the end of March. And we it's really very, very difficult to know at the moment about what the position is going to be on the 1st of April for so many of these funds. And there's shouting and yelling going on, and the NHS is just the same, as making the same noises up. And I can only imagine that the Treasury is trying to balance off all of these things, but people feel like they're right up against a cliff face now. So I'm not dismissing what you're saying. I'm just trying to acknowledge that the complexity of the problems you're facing is understood by the representatives of the sector in the stakeholder meetings.
All I would say is I think the WhatsApp group has really highlighted, and these amazing webinars, to be fair, and the amazing effort Devon County Council have done, but it has highlighted that we all genuinely care. We're not in it for the money, well, that's the impression I get from nearly everyone I talk to. And in the beginning, when it first happened, we had 8 weeks of total silence from our so-called inspectorate and everyone trying to help us, and we did collectively, we sorted the problem out ourselves. And I just think that the grants have helped massively. I think, like Shreya said, we haven't thought about the cost, or a lot of us, we've just done it because it was the right thing to do. Just like I've signed 3 staff up for MVQ level 2, 3 and 4 because they want to improve their skills. And going forward, I think you need some people from the grassroots that are on the floor that have brought us through this, talking to the people so they get a better feel for what we've really done and how amazing the collective has come together and solved the problem.
Well, Nick, if you would like me to mention your name, and I need your details, to the minister for one of her virtual visits, and particularly because you're of a small care home, and are you an individual one? Is it just?
Yeah, one. I'm a single home. Been here 20 years.
Yeah. If there's somebody else that's in a single small home as well, we're trying to raise their awareness, because the corporates shout loudly, don't they? They tend to have a loud voice, and so making sure that the pattern of small individual homes has been really important for the provision of care and for the care quality as well. And I know that. So it's an important part of the sector that needs to be heard. So let me know.
And we offer choice, don't we? Because
on the chat.
And we offer choice, don't we? If you've got small providers, it gives people
my
choice.
email's on the chat. Specifically, if you're small and a single, or 2 at the most, small, because I'm trying to get that voice of the sector. See if the minister would be interested.
Okay, fab.
Lovely. I am conscious of the time. It is 3 o'clock, so I think for now I'd like to thank you, Claire and Dan, for joining this call. Shireen, did you want to say something?
Just before you let everyone go, if you haven't done the fee consultation survey, please answer the email. If you want to see the results, I've just put one of the results links in the chat bar, so you can say, I'm just thinking about committing yourself to giving us data. You can see the outcome. I learned that from this call today, so thank you for the sharing best practice call. But if you can answer the fee consultation survey, I'll love you forever.
And on that note as well, there was a survey sent out, I think it was last week, about these sharing best practice sessions, and we would really like to hear from everyone what you would be interested in talking about over the next 12 months. So if you've got any ideas, please can you fill out the survey? I think, Izzy, will you send it out again? So that would be really helpful. Thank you.
Thank you for inviting us.
Very nice of you to come. Thank you.
Thank you very much.
Okay, take care.
Thanks.
Bye.
I'll look at the chat now. Okay.
Thanks,
Bye.
everybody.
Thanks.